all of you got a little bit of a base understanding about autism. So now what we are going to do is we are going to look at some videos and understand what features of the DSM-5 are there. So we talked about DSM-5, but we actually did not tell how many criteria should be there and what are the specific specifiers of each criteria. So while we are looking at videos, we are going to do it. Now, as both previous speakers very clearly mentioned, autism diagnosis is quite complex. So that's why we miss it. So let's say there is something like clubbing, we are not going to miss it. If there's something like cyanosis, we are not going to miss it. If there's something like jaundice, we are not going to miss it. But this is all behavioral, right? There's no diagnostic investigation to diagnose autism. So depending on the competencies of the clinician who sees the child, only you will be able to diagnose. So multiple times you will visit the same clinician and the parents might say, child is not yet speaking, but then you would say, just let's wait and see for another few months. So actually in autism diagnostic criteria also, there's nothing called delayed speech. Fortunately or unfortunately, right? So there's nothing called delayed speech in the diagnostic criteria. If you go through each item, there's nothing called delayed speech. That is purposefully because children with autism have this amazing ability to talk. Even as young as like 10 months, they might start talking. But they don't talk sense. But we think parents assume they talk sense because they will be saying 1, 2, 3, 4, 5. So they will be counting up to 100 by 2 years. So amazing, brilliant kid, right? Knows all the colors, right? Whatever they hear, they might be able to say. So that is echolalia, delayed echolalia. So, but the words are there. So therefore, speech delay is not a diagnostic criteria. So why it is not there? There's a reason, right? So if you look at the criteria, we have, as Dilni and Dr. Darshini said, there are two main criteria. One is about social communication and interaction. The other one is about restricted repetitive behaviors, right? So out of the social communication and interaction, there are three core groups. So out of those core groups, all three should be compulsory present to diagnose autism. But to identify that, you have to have the observation powers. Sometimes very subtle features are there. Then in the restricted repetitive behavior category, out of 4 core symptoms, 2 are adequate, right? So you have this paper. Take a look at it. You would be able to see those very specifically outlined. Now in our clinic, any child who comes with speech delay, difficult behaviors, not yet participating in the preschool, they all get screened by the DSM-5. If the doctors and the therapists are competent, this form will take less than 10 minutes. Even 5 minutes, you can fill this form, right? You just need to observe the child. When they walk through the door, you can fill in a few, right? But you have to become competent and it's very easy. Even in a busy clinic, you should be able to fill this form. Why we don't use MChat is actually very sensitive if it is done by a properly trained doctor. Very difficult. We have MChat filled by some community staff, but if we fill the MChat ourselves, there are a lot of discrepancies. So MChat is not a very sensitive screener for Sri Lankan context because people don't understand to ask questions. But DSM-5 is observation and you can do that, right? So I will run through each of these, but before that, I just want to show you. So autism begins very, very early in life. And I'm going to show you a little video of two babies who are both coming for their 3-month assessment, right? So one is a sibling of a child with autism. The other one is a child who had sepsis, meningitis complications and come into our at-risk clinic. So just observe these two videos. What is the most striking feature in the two babies? What is the most striking feature? I agree, there is a little bit of refusal to look at the mother, not very happy to interact.
Not maintaining the eye contact, or maybe not, just because though the child pays eye contact, it's not kind of meaningful eye contact.
Okay, good. The child is looking, but so what is meaningful eye contact? So this is what I am saying. Autism diagnosis competencies to become a developmental pediatrician is subtle and it's very specific. It's not easy, right? So actually what we see is also the social expressions of the eye contact. The other baby smiles not only with the mouth, but also with the whole face. There's an entire facial expression that changes, which also moves to the body, right? So that is a social human being, right? Humans are social beings. That is disappearing in our genome. So it's a bit of a scary message that we are getting, right? So maybe we all need to start laughing, smiling, interacting, being happy, right? Learn to smile with everybody you meet. Big smile every day, because it'll probably pass through the genomes, especially the young people, right? There is something happening in the evolution. Something scary happening in the evolution, right? So this is all described. There's postulation, how this happens neurodevelopmentally. We will put it into the drive. That drive will be available for you all for 1 week. After that, we'll delete it. So if you want to download anything, we'll put it in the drive. There's a very new article that came out about early autism, right? You can see the other babies also aware the mother. So the baby is responding. So in very early life, children with autism are like this. They are struggling to make that connection, but even their expressions are not adequate. So what happens is that mother-child serve-return interaction does not get established, right? So that is a bit of pathology. Sorry, I slightly deviated. But this is the beginning of joint attention. And joint attention is the key deficit in autism, right? So you will see what joint attention is as we go by.
Here that baby was interested in that toy and mother is asking to give it, and she's not giving and she's taking by force, and she's trying to get her attention, but she's reluctant to give the attention what mother says.
Yeah, so out of this, which one will you?
Reduce sharing.
Yeah, so reduce sharing of interest, reduce sharing of emotions and effects. So there is no back and forth smiling, there is no mother is asking for the toy but still not even sharing it, right? Playing by themselves. So there is not only social communication interaction difficulties shown in this. In the next part also we can tick the box for this kid, right? Because there is restricted use. And also now these are twins. There are two kids. Now, which one do you think is affected?
This one.
Which one do you think is affected? Twins. Or do you think both are affected?
Both are affected.
Both twins affected? Neither of them are playing with each other. Both of them are more concerned about what they have rotating. One is rotating the tire, what do you call it? The floater. The other one is obsessed with the octopus, right? Yes. Also, you can see a sensory feature putting it in the mouth. So, already this kid automatically falls into autism. Why? Solitary play. Solitary play is in A3. So in A1, we have already identified failure of normal back and forth conversation, reduced sharing of interest, reduced sharing of emotion, lack of initiation of social interaction. So all those A1, all sub-criteria are filled. In A2, you don't see eye contact, social use of eye contact. We also hear, if you hear her talking well, you hear her talking with an abnormal pattern of intonation.
The oh, and then there would also be sometimes a moment.
So that you can hear very briefly, not very well. But all children with autism, if you put them together, they all talk with that kind of accent, right? So that is also coming on the A2. In the A2, if you look at A2, also you can see that is abnormal pitch, intonation, rate, rhythm, stress, prosody or volume in speech. That is ticked. Then abnormalities, impairment in the use of facial expression. That is also ticked. And in A3, we will be ticking difficulties in sharing imaginative play, prefers to play by themselves, right? Absence of interest in others. The last one before starting B, okay? So this little one, also you can hear the jargon, as Nadini quite rightly pointed out. That is jargon. She's saying, hello, hello, like that, right? So there is a tune that is being repeated. And also, she's rotating the same, rotating the octopus, the same toy. And then she's also putting things in the mouth, which is a sensory one. That is B4, right? So 1 minute video can pick up the entire autism diagnosis. Simple, right? No? It's very difficult. You can diagnose in 1 minute, but you need to spend 1 hour to explain to people why you are labeling their child who's so cute and who is doing such cute things as having a neurodevelopmental condition that might affect their lifetime. So one conversation may not be enough. You might have to have many conversations with the families and very gently break the news to them. But you can't take a lot of time. Okay? So this is a 1 minute video and we can diagnose autism, right? All features are ticked in the boxes. Right.
Yeah. Do you want to start with the DSM-5 from A1?
There's no joint attention observed. We are talking about A1, and there's reduced sharing of interest seen, and there is failure of normal back and forth conversation as well. Only mother is interacting with the child. We don't see any response from the child's end. And there's like poor response for his name. In A2, there's impairment in the social use of eye contact. We saw only very brief episode. And in A3, with the maintaining of relationships, there is deficits in developing and maintaining relationships.
Okay, so we are talking about social communication deficits. So you can see mother is so affectionately talking to the child, touching. So there's very limited reciprocity even in the emotions, how much he reflects back those emotions. And you can see, as Sajani mentioned, so lack of facial expressions, limited interest sharing, and then even when mother started the bus, so there's no imaginatory play. So he's not involved in that play. He's not even demonstrating he can imagine and play. So we went through a lot of things in that. So abnormal, back and forth conversation, reduced sharing of interest, reduced sharing of emotions, impairment of social use of eye contact, abnormalities of, lack of coordinated verbal and non-verbal communication, and difficulties in sharing imaginative play. Okay?
So in this kid, lot of, if this is just a tape, if a child has lot of A1, that is very likely to be autism. Right? But remember, this has to be kids whose hearing is assessed and hearing is normal. Right? So hearing assessment is mandatory before you confirm the diagnosis. Right? So if there's lot of A, and if when the A starts disappearing, we are very happy, right? Because A is the most difficult one to get out of, right? So if you look at eye contact, he gives very good eye contact, right? But look at him looking at the mother in a very puzzled manner. Why are you bothering me, right? Leave me alone. I just want to do my stuff. So these are the ones who come to see Dr. Darshini, right? So this kid has a dad who is very silent. So the mom said, I thought I just watched because he's so much like the dad. Dad also doesn't want to be disturbed. Right? So the genetics. So not requesting. Right? Okay. So sad. He's basically pushed behind that table, and this mom is a super mom. This kid is also like, he's now in Canada and he's doing amazingly. Like he's really good. But he's still very soft in his verbal responses. He talks less. That's good, right? You don't need to talk so much. Our very, very close dear colleagues, she is going to Australia soon. So that's a session. Now, Dilin is going to walk around asking you all for specific features in each criteria. So this is a tough one, right? For you all, because most of you all are seeing this for the first time. Straightforward for people who are already working in the discipline.
So we'll start with group 1. So can you tell me, so what are the deficits in social emotional reciprocity you noticed in this video? You can share an answer or one person can answer.
So actually he is not respond to the his name initially. So I'm going to A1, and not sharing also is a obvious one. He's trying to to play with himself. And I'm going to A2. There are some. Okay, sure. Okay, when I see this video, first of all, it seems to be unusual social interaction, and he's not going to initiate the conversation also. And he's not respond to his name. He's trying to do their work himself and reduce sharing of emotion as well as the sharing. No smiling here.
Thanks. So joint attention, you can see to certain degree, he's, when the therapist shows something, he looks at it. So this is what you need to keep in mind. So it's not always nil. So what we are looking at, the degree of impairment as well as abnormal nature in certain features. Okay. So it's not always, you just tick it, okay, it's there. So why do you say? No, you look at the quality. It's very important. And even quality, okay, quality of response. So even the failure to respond to praise, like when the therapist was praising so much, but how much it was accepted by the child. Did he show that he got very happy when the therapist was praising? Okay. Initiation of social interactions, also like when he wanted something, rather than looking at the therapist, he was just peeping under the table. So when he wanted something, yeah? Okay, A2. We are in the group 2.
Reading glasses problem. Yeah. Deficits in non-verbal communication. Now he had all the features here, because to start with, impairment in social use of eye contact. He had impairment in social use of eye contact. Actually, he had all the features in A2. Impairment in the use and understanding of body postures facing away from the listener. Impairment in the use and understanding of gestures, pointing, waving. That also he did not have. Shaking, nodding of the head.
So he pointed
partially. Yeah.
Like this, but then he goes like this. Yeah?
Then abnormal volume, pitch, intonation, rate, rhythm. That also he was not very competent.
How he spoke. It's not very clear, but he was like in very high pitch, and he was like using a very different accent, but we hear usually from Sri Lanka speaking.
Yes. Then impairment in the use of facial expressions may be limited, or he had that also. Then lack of warm, joyful expressions directed at others. That also he did not have. Okay. Inability to recognize or interpret others' non-verbal expression. So he was not looking at the face, and he was not responding to her, talking her, everything, praising everything. And lack of coordinated verbal and non-verbal communication, that is also present. And
So like when he was pointing, he was either looking at the object. So like he was not looking at the object and looking at the therapist to let the therapist know that he wants something. So it was not coordinated.
yeah, so lack of coordinated non-verbal communication. Thank you.
Thank you. Wonderful. Anything to add for A2?
So this therapist is very good, and she is doing it in a very stimulatory way. So is it, I'm just asking, now as for us as clinicians, is it fair to do the DSMV in this level of a stimulatory environment? Because behaviors that are usually not there, at this session, she is able to bring out through her interactions. So I'm just saying, if we are doing the DSM-5, looking at this level of this kind of a context, would we get a good idea about the child? Or should we see it in a more natural context?
We should be trying to play with them, or they should be playing by themselves. But if it is positive, it is positive. This child will show these features anywhere without, he will be behaving like this. Or even he will be, I think he's under a little bit of control with the therapist, but he will show all these features and maybe even more if he's in the unstructured setup. We are coming to the more interesting ones with the B.
Yeah, so as that's one important thing, the observation really matters when you think about the quality of interaction. So you sometimes, as you said, the caregiver, how the caregiver interacts may bring out certain things, but the quality, you can see the difference. So, autism would not change. So it's a pervasive thing, it won't change from here to there. But what you see, the responses might differ, yes. Okay, so... So A3, I think I gave to both 3 and 4.
There is an accent sometimes. Accent is there. Sometimes accent is there in speech. And sometimes he's walking around the table finding something, not responding to the addressing thing. Sometimes finding something walking around the table like that. And some actions are there, not like this, like this, yes.
He tries to relate to the therapist, but he's not maintaining it. He's more interested about the toy and getting the toy, grabbing the toy and doing what he wants rather than doing it in a relational way with the therapist. Right? So that is not there, right? So deficits in developing and maintaining relationships appropriate to developmental level. So at this age, child should be able to say, Auntie mama tenang, auntie teka selang karana, mama asai me satara. Like that. So it's just, there is no social communication also. It doesn't matter if there are children who can't talk, but again, that way he tries to grab things is not appropriate, right? What else?
Anything else? So like even the theory of mind. So like when the therapist was trying to get the attention to something, he didn't follow. So
I feel that there are at times there are inappropriate expressions as well, madam. That the child is all of a sudden making abnormal sound, just like inappropriate expressions of emotion, laughing or smiling. And the limited interest as well, because child is engaging, but the interests are limited although.
There's difficulties in sharing imaginative play. And mostly the solitary kind of play is there.
Lack of interest in the other person. We have a speaker waiting from USA, so that's why we are. Nisha is in US, so she will be joining. It's quite late for her. So
yeah, so B1 and B2 was your task, right?
Madam, stereotype complex body move. Can see some complex body movement is standing and sitting and standing frequently.
So under repetitive speech, there was repetitive vocalizations, unusual noise making, and like he always kept getting up all the time. Yeah. And also the stereotype of repetitive use of objects. Yeah. Did I miss anything? Yes. Yeah, that one.
Some restriction to do.
We are doing B2, B3 as well. B3 is that.
So yeah.
Lines up toys.
So So you can see if you go to the B1 and B2, so we are talking about restricted and repetitive movements, and that's a repetitive and stereotype speech. So the intonation, you can hear what he was started something, nobody understood what he said. So it's jargon speech, and he had a lot of echolalia. So when the therapist said thank you, he was saying thank you. So he was, even delay. Yeah, there was even delayed echolalia. Yeah. So it was after some time it came, not immediately.
So that is something that somebody does with him all the time. It's okay. Echolalia is good. We want children with autism to get echolalia because that is the way children learn, and he uses it appropriately. But when you know that it is something that he is in a very structured manner, he's repeating, oopsie. Right, so that's a delayed echolalia. And also, I don't know whether you have heard it. In this, there's something in B1 called like guttural sounds. And last
Here, this one or this one? This one.
Last echo.
Yeah, this one.
Repetitive vocalization such as repetitive guttural sounds. Did you all hear that? Like he makes a sound like ah. Did you all hear that? I don't know if you very clearly you අර මේ උගුර පාදනවා වගේ එකක්. So he does that in that video.
Actually, the child doesn't show much of the symptoms of features of B3 and B4. He was showing the interests that are abnormal in intensity, and also he showed some narrow range of interests. He was playing with the same kind of toys, so we thought of he's having some narrow range of interests and focusing on the same objects. Like, so he doesn't actually show the much of the features of these B3 and B4. So B4, we couldn't see any sensory features that the child was showing.
B3 is about your interests and the fixated interest, and B4 is about hypo and hypersensitivity to sensory stimuli. So he at once he was going very close to a toy, so you can see children getting very visually close, inspecting. But most of these features, that's why it's important you go through the history, so you can, because some of these ones you might not be able to elicit then and there, but the history really matters when it comes to the sensory profile of the child.
So you all can see this is a very short video. There's more to this video. We have broken this into parts. There's in one activity he's lining up. Now do you all believe what I say? DSM-5 doesn't take time, but it needs competencies. Right? So we have watched very short videos, all less than 5 minutes. And we have managed to diagnose how many children? 4 kids with autism, right? So keep your eyes open, keep your ears open. When Nimisha finishes and when we go back to other videos, we will try to show you all that intonation pattern that we were talking about, all this posh sounding talking that we might hear in our clinics. Right? Just stop and see what these kids are, right? Playing with the toys. We didn't show the common ones. We showed you all very uncommon and subtle ones, because common ones, Rodha Karakavana, you all know. Everybody knows to catch that name. Harida. Okay, so Dr. Nimisha Muttaya, she's speaking from USA. She's again one of our team members who decided to leave. But hopefully she might be back. She's going to talk to you all about assessments, specifically with regard to speech and language assessments, speech-language communication assessments, because core feature is social communication and interaction. We have to arrive at a very good assessment, right? So we have done the medical assessment now. The DSM-5 is there. By the way, ADOS was done in Sri Lanka by only 2 people. One is Nimisha, one is Dilini. Those are the only 2 people qualified from Sri Lanka. I haven't qualified in ADOS. I think Dr. Manure would have done it, right? Okay, so hopefully all the developmental community pediatricians are requested to train in ADOS and come back. ADOS takes a long time. DSM-5 is done within 5 minutes. Okay, over to you, Nimisha.
So when you're gathering information from the parent, it's always good to think about doing some objective standardized measures. So for example, one that you can complete is called the REELS, the Receptive and Expressive Emergent Language Scale. If anyone would like more information about that, I'd be happy to share about that as well. Also, you can informally gather information from the parent by talking to them and asking them about their concerns and anything else about the child. So the second thing that I mentioned is to observe the child, right? So I know a little while ago, in groups, you were observing the videos that Prof. Salman Mali and Dr. Dilini were showing. And there's so much value in the amount of information you can gather just through an observation. So it's really important that we observe the child during play, while interacting with the parent, and then also while interacting with you as somebody who is unfamiliar. Because that will also tell you some different things. But you need to make sure you get an adequate observation that is actually a true representation of the child's skills. So sometimes when I see a child in the clinic, I ask the parent, like, is this how your child behaves at home also, or is this different? So that's really important to know, because sometimes children can act very differently in an unfamiliar place, right? In a place that's new to them. So the third thing is to interact directly with the child, right? So through that, like I said before, you can gather a lot of information or to complete an assessment directly with the child. So you can use various types of activities to do that. It doesn't need to be an objective assessment itself. You can have a conversation with the child. You can just play with the child and see how the child is interacting with you, how they're interacting with the toys, how they're reciprocating or responding back to you. Or you can just look at a picture book together with the child and see how they respond to that. And you can also complete a standardized assessment while interacting with the child. So for example, an assessment like the Rossetti. So the Rossetti is an assessment that allows you to score as you are interacting with the child. You can either score it through observation, or you can do what's known as eliciting a behavior. So the Rossetti will have specific skills that you can try to elicit through the child. So it might say something like, is the child able to identify an object out of 5 objects? And so you can actually do it in that moment and see whether the child is able to complete that. Or you can ask the parent the questions, and then it would be as reported by the parent. So the Rossetti is kind of unique. It's a unique assessment that allows you to score it in these 3 different ways. So it's always good to try to complete at least one objective assessment. And when I mean objective, it's some kind of a standardized assessment. So an objective speech and language assessment, especially when we're talking about children with autism, we know that their main areas of deficits are social communication and restricted and repetitive behaviors, but that communication aspect is so important. And so doing an objective assessment to gather information on that aspect is really essential. So it will give you a good idea, especially an objective assessment, of how far below the normative that child's skills may be. And it will also tell you at what developmental level the child is currently at. So a child might actually be, the chronological age might be 5, but the speech and language skills might be functioning only at the level of a 2-year-old. So this is really important too, right? So a lot of clinicians or therapists think that assessment needs to happen in a therapy room. So I've had clinicians tell me, So the thing is, assessment doesn't need to happen in a therapy room, right? It can happen outside, it can happen in any setting. So it's really up to the clinician to be flexible and have that flexibility. It can happen anywhere. So along with the objective assessments, I would also say always complete an informal assessment as well as an observation. And the reason for that is, especially in Sri Lanka, we don't have linguistically and culturally appropriate assessment tools that we can use with our children who have autism. For a child, if you see a child who is under 3 years, always think about using an objective assessment like the Rossetti or the REALS, because it will give you a lot of information that you can use in your therapy session as well. And for older children, think about using more informal means to gather information. Okay, so I'd like everyone in the room to scan the QR code. So take a second and scan it. So just pull out your phone, and when you go to the camera, it should scan the code. Hopefully everyone is doing that right now. Okay, I am going to share something else here in a second. So I want you to ask. Hopefully everyone can see this on the screen. Okay. No one has responded yet. So I hope everyone had a chance to, yeah, yes, yeah, Dilini. Go back to the QR code. Got it. Okay. All right. So this is the first time I'm trying to do this. Hopefully it will work. All right. So scan the QR code. It's asking you a question, right? The question is whether you're able to do an objective assessment in your setting. Yes, no, or sometimes. It's an anonymous survey, so even if you put your name in, no one will see it. Okay, so you can really answer as truthfully as possible. Okay, I hope everyone had time now. I'll just give a few more seconds here before I go to the results. And again, like I said, be honest. I know that it is difficult to do objective assessments. So when I'm talking about objective assessments, it could be the DSM-5 checklist, it could be the MCHAT, it could be a speech and language assessment, whatever, but an objective assessment. All right, let's go to the results. Let's see what people are saying. All right, I hope everyone can see this. Okay, so let's see. Wow, so 50% of you, people are changing their answers. Like I said, no one can see your responses, okay? So it's okay. So we have 58%, okay, 60% who are saying yes. And then a little percentage saying no, and then sometimes. So a majority of you are completing objective assessments when you see a child with autism, which is really good, which is excellent. Okay, here's the next question I have. So stay on that screen. If you don't always do an objective assessment, what's the reason? What's the reason? So you can type in an answer for that. So reason why you don't always do an assessment, for those who are sometimes, and for those of you who say no. Again, no names, just your responses. Time. Crowded clinic, poor knowledge. Any others? Lack of time. No, that's okay. Okay. All right. Okay. So I think we're seeing the same responses again and again. Okay. Yeah, agreed. Some are not applicable for the Sri Lankan context. Not enough space to complete it. Okay. Not culturally appropriate. Yes, but there are assessments that are culturally appropriate, and there are assessments that we can adapt to make it culturally appropriate, or that we have adapted as well. So like Dr. Dilni shared, the MCHAT is one. The DSM-5 checklist is another one. It's not adapted for the Sri Lankan context, but where you're just using it as an observation tool. Lack of time. Okay, great. Thank you so much for your responses. All right, let's go back to my point. Keep your phones up because there's going to be one more poll question that I'm going to ask in a second. Okay, so now I'm going to specifically talk about assessments for children with autism or children who are on the autism spectrum. So especially the speech and language therapists who are in the audience, definitely you should always assess the two main areas of deficits, the social communication skills and the RRBs. Okay, we should be looking in detail at those two areas. In terms of the social communication skills, there are specific social communication skills assessments and checklists that are out there that are freely available. There are paid ones, but there are also ones that are freely available. Again, they have not been standardized for the Sri Lankan population, but if we do one of these checklists, it will still give you a good idea. It will give you some qualitative information about the child. That's really important. With children who are younger than 5, remember that it's really essential to look at the caregiver interaction with the child. And I know later on in today's workshop, you're going to talk about the QSIT. And this is that kind of an assessment where you look at the interaction between the child and the parent. So remember to observe their interaction during play. That's really essential when you're seeing a child with ASD who is younger than 5. Like I said before, you can also complete an assessment that specifically looks at caregiver skills, such as the QSIT. You should always complete a specific speech and language assessment for children who are on the autism spectrum. Even though it is not one of the core areas of deficits, we know that children with autism struggle with the area of communication. And we know how closely communication and social interaction are. They go hand in hand, which is why now we refer to that aspect as social communication. And in addition, the research tells us that almost 1/3 of children with autism are minimally verbal or don't have functional communication skills. So here's another aspect of looking at children who are on the autism spectrum in terms of their communication. Remember, there are many children with autism who are good at labeling and naming, right? Those rote language skills, but they really struggle in the area of pragmatics. So when you're assessing them in your clinic, you should be doing more than labeling. You should check their pragmatic skills. And when I'm talking about pragmatic skills, I'm specifically talking about their use of language, their social use of language for a variety of functions, like the ability to have a conversation, to share information with others, to ask questions, to answer questions. These are some of the pragmatic skills that you should be looking at, even informally. It doesn't have to be an objective formal assessment. And we know that some children with autism have good language skills, and they even might be able to speak really well in sentences. But even those children who are have good language skills will still struggle in social situations and will still struggle with things like forming friendships. You should be assessing theory of mind in children who are older than 4 years. Theory of mind is a concept that develops at the age of 4. And if you're seeing a child who you suspect is on the autism spectrum or has a diagnosis of autism, you should be trying to assess whether that child has that concept of theory of mind. So go ahead and scan the QR code again. Here's the next question. Let me pull it up on my screen. Okay, so the question is, what is theory of mind? So go ahead and scan the QR code, and we'll see the responses coming in. Again, it doesn't have to be like a textbook definition, just what you think it is. If you have heard of it before, if you know what it is, just go ahead and type it in. So what is theory of mind? Okay, let me share the screen so everybody can see this. Okay, so some people say no idea. How to interpret others' minds, knowing what others think, ability to think from another's perspective, thinking as someone else. And it's okay if you don't have any idea, it's okay. Think as another person's perspective. Understand things in others' points of view. Okay, good. It's a cognitive ability to try and, I think, identify others' mindset. Ability to understand that another person's perspective might differ from yours. Please explain it. Okay. Okay. Basically, theory of mind is being able to take on another person's perspective or see something from another person's point of view. Okay, I haven't. Okay. All right. So that's basically what theory of mind is, right? Being able to see something or understand something from another person's perspective. And we know that children who are on the autism spectrum really struggle with that concept of being able to take on another person's perspective or seeing something from another person's perspective. So how would we assess theory of mind in a clinical setting? So children who are between 4 and 6 years of age, if they have that concept of theory of mind, should be engaging in what's known as animated play. Okay, so say they're playing with puppets or characters like animals, they should be bringing them to life by giving them a voice and having a conversation, right? So say I have one puppet in my hand and the child has another puppet, we should be able to have a conversation. The child should be able to take on the role of the puppet that he or she is holding and have a conversation. That is one way of assessing theory of mind. In children who are older, like in children who are older than 6 years, we should be able to look at a picture book with them or looking at a picture, and the child should be able to infer how a person is feeling based on the situation in the picture. So for example, say there's a picture of a boy who has fallen down and he's bleeding. And if we ask the child a question like, how do you think that boy feels? The child should be able to think like the boy who has fallen down and say he's hurting or ouch or something that is appropriate to that picture. Being able to think like that boy who has fallen down. So a good assessment is really important, is really essential to help you find a child's strengths and their difficulties. And if you do a thorough, comprehensive assessment, it will also help you to narrow down on your goals and what you need to focus on first with a child. Doing a good assessment will also help you to measure progress over time, right? Because if we assess the child now and then we reassess the child in a year's time, we will be able to see the progress or the difference or the improvements that the child has made. Okay, that's all I had. Any questions or thoughts? I'll be happy to answer. I do have a question that I want to put out to Prof. Samanmuli or Dr. Dilini. We had one person who is a general pediatrician who said that they don't complete objective assessments. I think it's important to address that because an assessment, a screening tool such as the MCHAT, or even the other one that Dr. Dilini shared, I think those are assessments that should be completed by general pediatricians as well. Would one of you mind answering that? I didn't. No, No, so I said one person on the poll said that they're a general pediatrician and they don't complete objective assessments. I think it's important to address that because they have a big role to play in that.
I think that is something probably we need to work on as teams, and that's what we are doing as capacity building. We have MChat at least, to a certain degree, which still not used, but at least, so we should be trying to get it across, isn't it, madam? Now, after this, probably we can share the screening tools we use at IATA, so the teams can take it into practice and see how much you do it in the practice, because the midwives at the public health level, it's not implemented yet. So what the best thing we can do whenever a child presents to us, so for instance, the recommendation from American Academy of Pediatrics is because their system, you're supposed to go for regular development, the regular medical, assessments, screening. So your immunization, everything is being checked, and the part of it is development. And in that, they still recommend to have an autism specific screening between 18 to 24 months. So,
They are doing it starting from 9 months, 24 months, and then autism specific begins at 12 months, didn't Nimisha? In the US.
I think, from 12.
Yeah, 12 months. But they are trying to push it to an early age. But now, so this is the beginning. So I think Jayatri is here. So SLACD is taking the leadership in making our doctors and all the other teams getting aware about child development. It's not easy because there are only few people having the competencies, and we have to go around and deliver this as well. So we are overwhelmed with numbers. At IIT we have 10,000 plus registrants, and waiting time to see a consultant is 2 years at IIT. So it's not possible for us to do all the work. So that's why let's start. Please join. We'll make people aware, and we have to have longer workshops to teach about MChat, etc. MChat is a bit of a tedious task, right? So at least the DSM-5, I think, Nimisha, now, I think after today, people will start. So Dr. Jayatri is here, Nimisha.
Can I add something also, Nimisha?
Sure, please do.
I'm not seen, is it? Yeah, hi. I should say, rather than asking, are you not doing, we have to, I know what the difficulty is, yes. We need to introduce these things one by one and tell that we also didn't know earlier. We'll put it that way, because we all are struggling with numbers and, the, trained labor, everything. And we are at a crisis that people who are skilled are leaving this country. So we have to, that's a big problem. Yes. So all these problems are there. I mean, people might find it intimidating to tell that, are you doing this? So we are here to do it together, isn't it? So, yeah.
A lot of public awareness. So in Colombo now, parents come.
Thanks.
At 3 months, 4 months, they come. Child is not smiling. Child is not looking at me. So maybe a lot of posters. Api wena vidit hitanna anything. Api langata enne epai api assess karanna. Avilla kiwuwot, of course we have to assess. I think that we have to say. But yeah. Okay, Nimisha. I hope we answered your question. Yeah? Any question?
One more thing.
Yeah.
One more thing. People had brought up that they didn't have time to do the objective assessments. So I just want to address that very quickly too, and I acknowledge that. I think being familiar with the assessments is the first step. So yeah, I think that's a place to start.
Yeah.
Thank you.
Yeah, thanks. So even this is why we need teams. This is why we need community pediatricians who are dedicated to train and trained in that job. So even if we don't have community pediatricians training and coming from abroad, we have to think about training our general pediatricians into that job, just like we did for neonatology, so that they can have teams and the teams can work. So the pediatrician doesn't need to do the assessments, others can do the assessments, we can come together as teams. So we have to look at options based on the facilities we have. And time should not be a barrier. Okay? So, thank you, Nimisha. Any questions for Dr. Muttaya? No questions? Okay, thanks, Nimisha. Good night. Thank you.
දරුවා අවුරුදු දෙක පසුවෙත් පැහැදිලි වචන කතා නොකිරීම ඕටිසම් තත්ත්වයේ ලක්ෂණයක් විය හැකියි. ඕටිසම් ලදරුවියේදීම හඳුනාගතහොත් හොඳින් පාලනය කළ හැකියි. නොපමාව අමතන්න 117 SLACD සහ CDB සාමූහික මෙහෙවරක්.
If your child has not spoken clear words by 2 years of age, it could be a sign of autism. Autism can be successfully managed if identified at an early age. Call our helpline on 0117490000, a joint effort by the SLACD and CDB.
குழந்தை 2 வயதுக்கு பின்னரும் தெளிவாக பேசாவிடின் அது ஓட்டிசத்தின் அறிகுறியாக இருக்கலாம். ஓட்டிசத்தை சிறு வயதிலேயே இனங்கண்டு கொண்டால் அதனை கட்டுப்படுத்தலாம். தாமதியாது அழையுங்கள் 0117 490 000. இது SLACD மற்றும் CDB இணைந்து செயற்திட்டம்.